Hi everyone. If you are watching this video as part of my workshop series, thank you so much for being here. If this is the first video that you've watched, if you wouldn't mind just taking a second to scan this QR code up on your screen and fill out my pre-assessment. This is just part of my capstone, making sure that I have pre-assessment data, and then I'll have everyone who participates fill out the same survey at the end, just to show how things have changed over time and if my presentations were helpful, to kind of demonstrate exactly how helpful and maybe where additional work needs to be done. Now that you've done that, if you needed to, we're going to talk a little bit about cancer-related chronic pain and regular chronic pain that is related to other causes. To briefly introduce myself for those of you that maybe I haven't met or have only talked a little bit to, my name is Caitlin Jensen. I am a doctoral capstone student from Touro University Nevada out in Henderson in the Occupational Therapy program. I am doing my capstone as my final semester, focusing on comprehensive pain assessment and management, specifically working with cancer survivors. What I'm hoping that you will find after this presentation today, though, is that while I'm specifically focusing on cancer survivors and how we look at and treat chronic pain related to either cancer or its treatment, a lot of these strategies can be applied regardless of your patient's diagnosis. I also, just as a last little housekeeping thing, if you are interested in watching any of these other presentations, I do these presentations in person about every other week. You attend 3 of the 4 presentations, or for my virtual viewers, if you watch 3 of the 4 presentations, as well as completing my pre and post assessments, you'll be entered to win an Amazon gift card. I have 5 gift cards to give away for those of you who are willing to participate in my capstone program. Now that we've kind of gotten that out of the way, let's go ahead and get started and talking about some differences in looking at cancer and non-cancer related chronic pain. Just as a disclaimer, this is going to be the disclaimer for all of my presentations. Like I've said before, this presentation was created as a part of my doctoral capstone project while I've been here at Encompass Health Desert Canyon. I am still a student, but all of my materials have been developed from rigorous advanced practice research, continuing education courses, interdisciplinary observation. This is what I've been doing full time while I have been here at Encompass for my capstone. So there is a lot of evidence behind what I'm doing. But as always, you are the expert on your patients, so please use your professional judgment. Here are today's objectives, but I want to just jump in here. First, talking about the basic pathway of how pain works, some of these basic mechanisms. For a lot of you, I'm probably throwing things back all the way to the beginning of your schooling, but just kind of a brief overview of the basic mechanisms of pain. When we experience some kind of input that will eventually process as pain, the first step, we're not even going to have processed it as pain yet. We'll take some kind of input, typically for a lot of like musculoskeletal pain. It will be through different receptors in either the skin or the muscle, or receptors in the organ called nociceptors. These nociceptors will cause the release of neurotransmitters or chemicals that are going to end up causing an electrical impulse to move through the nerves. And so we're starting with some kind of receptor being activated here. It's causing the release of those neurotransmitters, which is going to activate what's called an action potential in the nervous system. This signal is going to travel through the peripheral nerves into the spinal cord, and it's going to travel all the way up to the spinal cord in the brain, where it will then be processed. When the brain processes this information, that is where we are going to feel the sensation of pain. The brain is going to be what is telling our body that the sensation we're experiencing is painful. Then it's going to tell the body what to do. So we've had that processing in the brain. Now the brain is going to send a response back down through the nerves, through the spinal cord, and then out to the peripheral nerves, where it is going to then tell, if we need it to, our body how to respond, or it's where we're going to really have that sensation of pain. Now that we kind of have that basic pathway of how pain generally works, I want to talk a little bit about the different types of pain. We're going to talk a little bit about nociceptive, neuropathic, and neuroplastic pain. These are the general three categories. And then in the past couple of years, the International Association for the Study of Pain, or IASP, and the World Health Organization, or WHO is how I'll be referring it for the rest of this presentation, have come up with some subcategories of chronic pain. So I will introduce the three main categories and then what some of those new classifications are. The first one is going to be nociceptive pain. Nociceptive pain is going to be the pain that we think about when we think about pain. Nociceptive pain is what we understand as being caused by either damage or inflammation or a threat of damage to bodily tissues. For someone experiencing nociceptive pain, they may name what it feels like as either sharp or throbbing or aching or cramping. Some types of nociceptive pain, I'm going to come back to chronic cancer pain, since that is kind of the focus of my capstone, and I want to introduce it when we move on to neuropathic pain. But most common that we're going to see in inpatient rehab is going to be chronic secondary musculoskeletal pain. This is going to be pain that's caused by some kind of disease process. So when we think about arthritis or degenerative joint disease, those kinds of conditions are going to fall under this category. When we're talking about acute versus chronic pain, the time frame that's generally accepted is about 3 months. So that key factor with chronic musculoskeletal pain is going to be that persistent or recurring pain beyond either 3 months or longer. The other type that's going to fall into nociceptive pain is post-surgical or post-traumatic pain, which is going to be some kind of pain after a procedure or injury that, again, lasts longer than that 3 months past the trauma or past what is the general healing time. Going back to cancer pain a little bit, cancer pain is going to be a little unique in that cancer pain comes from either the illness, whether that be the primary tumor or when the cancer spreads throughout the body in what's called metastatic disease. It can also be caused by the methods that we use to treat cancer. A common pain experience that is related to cancer is called chemotherapy-induced peripheral neuropathy, or CIPN. And that is actually a type of neuropathic pain, which I'm going to get into next. So chronic cancer pain is going to fall into both of these categories. We can have nociceptive pain that's caused by cancer or its treatment. We can also have neuropathic pain caused by cancer, illness, or treatment. Where nociceptive pain is damage to either joints, bones, muscles, or those other body structures, neuropathic pain is specifically caused by damage to nerves in the nervous system. Someone with neuropathic pain may describe their sensations as either prickling, pins and needles, burning, itching can be another common term, or electric shock. Kind of like zapping or shooting pain can also be commonly reported. Chronic cancer pain is going to be one, whether that is pain by the cancer itself or the treatment. Here is that full definition for you that I didn't provide because I wanted to leave it here. The other type is our general neuropathic pain diagnosis, chronic neuropathic pain, which is going to be that pain caused by either a lesion, disease, or damage to the somatosensory system. The final type of pain is going to be called nociplastic pain. Nociplastic pain, the definition provided is it's kind of an umbrella term. If it's not nociceptive or neuropathic, likely it's nociplastic. And it's typically talked about in terms of conditions as opposed to symptom reporting terms. If you are trying to think of a way to remember nociplastic pain is typically caused when there's something that happens that causes the nervous system to become more sensitive. Some of these conditions that fall under this category are going to be fibromyalgia, central sensitization, which is going to be sensitivity of the central nervous system, and then complex regional pain syndrome, or CRPS. The big diagnosis category from IASP and WHO is going to be chronic primary pain. This is going to be pain that is, again, lasting longer than that 3-month period, that has some kind of significant effect on functional abilities or emotions that doesn't have a better explanation, that maybe falls into one of those other two categories. Now, why do I spend the time to talk about the different types of pain? Big reason is going to be that being able to understand and identify what type of pain your patient is experiencing can be helpful for you as a clinician in selecting additional assessments, treatment approaches, or intervention strategies that will be associated with better outcomes. There is some overlap in treatment strategies regardless of the type of pain, but using pain management strategies or intervention tools that are specifically created or specifically mentioned as useful in a specific type of pain is going to save time for you, save time for your patient, and is going to improve the likelihood that outcomes are going to be positive. For the remainder of the presentation, I want to just talk a little bit about some similarities and differences between pain that is directly related to cancer versus pain that is not related to cancer. The biggest difference is going to be in reporting and interference. When I talk about interference, what I mean is the relationship between pain severity and functional ability. You might have someone who constantly lives at maybe a 6 or a 7, but really doesn't have much of an effect on their life. They're able to do their daily activities more or less the same as they usually would. Whereas you may also have someone who maybe reports their pain is at a 2 or a 3, but they can't get out of bed. They are really, really high assist for transfers and functional mobility, ADLs, things like that. For non-cancer related pain, those with chronic pain that's not related to cancer tend to report pain at a higher rate and more severe pain than those with early stage cancers, thinking stage 1, stage 2. On the opposite end, those with later stage cancers, stage 3, stage 4, and those with metastatic disease tend to report pain that's more significant or more disabling. The current statistics that exist show that more than 70% of those with advanced disease report more significant and more disabling pain. Overall, cancer survivors are going to be less likely to share pain with their providers and their practitioners at all. This mostly comes with some misconceptions. Common misconceptions are going to include this idea of being a quote unquote good patient, where seeking pain relief or asking for pain medication or pain management methods is being seen as maybe being needy or being a bad patient. Some of this is internalized just beliefs of how things work in a hospital system, but unfortunately this also can come back to past healthcare experiences, how they've been treated when it comes to requesting for their pain management needs to be met in the past can affect how they report in the future. The other big difference with cancer pain is that more severe pain is going to be reported with those who have metastases to either the brain or in the bones. Looking at just some general effects of cancer pain and pain in general, really, pain is reported more severely for those with lower levels of health literacy. There's a lot of evidence that shows that understanding of how pain works, maybe why they have pain and what they can do about it, is associated with better outcomes and less interference in daily activities. There is also a relationship between adequate sleep, feelings of anxiety and depression, and self-efficacy, feeling like someone is able to actually manage their pain on their own. Those who have inadequate sleep or some negative relationships with those other factors typically will report higher intensity and higher interference when it comes to their pain. Same thing with routine disruption. If they are being interrupted in their activities, likely we're going to report more significant pain. And unfortunately, this is something that kind of all acts in a vicious cycle. If you've heard of the wheel of disability, it kind of works in that someone feels pain, so they aren't active. And we know that people who aren't active will decondition, which will cause more pain, which will cause them to not be active. And it just goes on and on. And this is a place where, as therapists, we can really make a difference. I'm going to kind of breeze through this because we've talked a little bit about this already, but similarities, cancer pain is going to be a lot more similar to other types of chronic pain than it is different. Cancer pain is now considered a subtype of chronic pain, and we've kind of transitioned into cancer survivors living longer with and beyond cancer. So cancer in a lot of ways is now considered a chronic disease that requires management. We're also going to see cancer survivors living with more comorbidities that might cause pain. So now we're kind of moving into handling pain that is directly from cancer or its treatment to now we're going to be managing pain for cancer survivors that may be caused by other things. Some differences I've mentioned, CIPN. CIPN is going to be unique to chemotherapy. There are going to be some considerations for the use of physical modalities that I'm going to talk about in the next presentation. And then breakthrough pain is not necessarily unique to cancer, but it is talked about most often with cancer survivors. Breakthrough pain is where someone who has a pretty solid pain management plan doesn't experience a whole lot of pain that affects their activities day to day. But if they're experiencing some kind of change or a change in activity, they may experience some pain. That pain that's breaking through the existing pain management plan is called breakthrough pain. Last thing that I'm going to cover here is comorbidities and chronic conditions. Like I said, we're seeing a decrease in mortality for most of the common cancers. We're kind of now shifting away from helping people live past cancer to now looking at increasing function and improving quality of life. What we'll end up finding, and again, I'm going to talk more in detail about this in the next presentation, is that those with a history of cancer are going to have a higher likelihood of cardiopulmonary conditions, fatigue, cognitive impairment, and then some increased rates of psychosocial impacts like depression and anxiety. And we'll also see that there is an increased risk of falling and fracturing for cancer survivors. I'll talk again a little more about that in the next presentation. But to give kind of a brief explanation as to why cancer survivors, just due to either the tumor or the treatment, are at higher risk for what's called a pathological fracture. And those bodily changes that happen across the course of cancer treatment isn't going to go away when the treatment finishes or when a person enters remission. The risk of fracturing can last later on, depending on what treatments were used. We're also going to see some age-related changes for those who are living longer past cancer or those who are being diagnosed later in life. We're also going to be dealing with comorbidities related to aging. With cancer treatment, we're also going to see what's called premature or accelerated aging, where cancer or the treatments used to manage cancer end up causing an accelerated rate of functional decline, where a cancer survivor is going to be they're going to present as if they were a little bit older than their same age counterpart that maybe didn't have cancer. Bottom line here for this presentation is that while there are some considerations and some key differences for cancer-related pain, especially during active treatment, the rehabilitation management for chronic pain is mostly going to be the same for both pain that's related to cancer and pain that's related to other causes. just kind of looking forward, I've touched on this a little bit at the beginning, but just as a refresh, this is going to be a 4-part series as part of my capstone. And while I'm doing these presentations, I'm also in the process of making a toolkit to leave at Encompass, just with some tools, quick free use assessments for managing pain, different intervention tools, and handouts for patients. If there is something that you would specifically like me to include, please let me know. If you are on site, I'm typically, if I'm not with patients, I'm in charting room A. I'm happy to either talk about specific patients you're working with, specific intervention tools that maybe you've tried in the past, or tools that maybe you would like to try, or even if you're having a problem and you don't know if there's anything out there specifically for it, I'm happy to chat about any of those things and create resources for those of you that need it. Other than that, here are my references. Thank you all so much for coming. Last thing here for virtual viewers, if you are interested in being a part of the gift card giveaway, if you'll just scan this other QR code, super short, basically it's just your name, which presentation you watched, and what you took away from it. Once you do that, I will add you to my list so you can be entered as well. Thank you so much and have a great one.